Good evening. Yeah, it is before marriage. Tell me why before marriage? So that there will not be any problem for husband and child, but no? Why only before marriage? Suppose a girl has attained puberty, why not at 13 years or 14 years? For sexual function. So why not after marriage? So that patient can hide from the boy. That's it. Why just before marriage? There is reason, because in a case of recanalization, once we do the recanalization, what will do? Did you read the procedure? Recanalization. In the recanalization, what they'll put is something like cup-like things, elastic cup, or they can make it with the skin of the patient. They'll cover it. So they will use that, so as if like some mold. It is called as vaginal mold, so that the opening will be maintained continuously. So just before the marriage, after that they will be having regular coitus, so that the whatever the opening we have created, it will not close. So if you are not going to do the surgery, or suppose if we do it early, regularly the patient has to put that mold, or else automatically it will close off whatever you have done. So after marriage anyway they will be having coitus and it will not close. That's the reason why we do just before marriage. Yesterday question, second question. Secreted from? Now you got the answer. Why it is blocked? So prostatic infection, it's just an infection. There can be any leukocytes or sperms. It is not going to cause agiospermia. Orchitis, there will be agiospermia. Okay, but what was the question? Agiospermia. But fructose is seen. So it indicates there is block. So what is normally from testis? Next, what is the structure? Prostata. Epididymis. From epididymis? Vas deferens. Next. Next what? Seminal vesicle. Okay. Next, beneath that immediately the prostate will be there. Next, urethra. So this is the thing. Okay. Voice. Yeah, we'll start up the class today. What is this leiomyomas? What is the other name of leiomyoma? Fibroid uterus. So nothing but fibroid uterus. So what are all the important things you can get in the fibroid? Very important topic for you. So all the degenerations, the age, the causative factors associated, every topic in the fibroid uterus was asked as a one bit. So which is the commonest benign tumor? Which is the commonest benign tumor? Lipoma, genital. So coming to, it is the nothing but the fibroid. So it is the commonest. What is the most common ovarian tumor in young female? Young female most common. Or most common ovarian tumor in pregnancy? Choriocarcinoma na. Ovarian tumor antnanu pakka. Choriocarcinoma ni తీసుకెళ్లి ఓవరీలో పెడతావా? Most common ovarian tumor in pregnancy. Ovarian mass or else dermoid. It is nothing but dermoid. Dermoid is the most common in pregnancy. Okay, in the anyway ovarian tumors we will deal that. That is also one of the very important topic. So coming to today's topic, it is the most common tumor of the uterus. Is it malignant? Can fibroid undergo malignancy changes? Definitely yes. It is called as leiomyosarcoma. What are all the risk factors for leiomyosarcoma? Suppose a fibroid uterus has come. How do you say it is malignant or benign? How can you say it is leiomyosarcoma? It's only a post-op diagnosis. Can we detect it early? Malignancy in a fibroid uterus. So what are all the risk factors for malignancy in a fibroid? When do you want to suspect a malignancy in a fibroid uterus? Age, exactly. What is the age? Yeah, purpura dermoid is the answer. Yeah, tell me, what is the risk case? Which age you want to suspect? So young age fibroid. I got a case yesterday, what I was telling you, it was fibroid uterus. So shall I suspect malignancy in such a patient? So which age you want to suspect? So any postmenopausal woman. So if she presented with the fibroid, but what's the management in a postmenopausal woman of fibroid uterus? You want to do surgery? You want to do surgery. Why in postmenopausal woman you want to do surgery? Tell me why the fibroid is formed first of all. Estrogen. Estrogen is dominant in which phase? Postmenopausal? Premenopausal? Which phase? It is most common in reproductive age group. That's why fibroid uterus we are seeing in the reproductive. That in a case of menopausal woman, what we will do? Suppose a menopause lady has come. She came with complaints of something like mild something like a cervical smear or general examination. On examination on routine ultrasound scan, I have found a small fibroid, 3 into 3 centimeters. Small or big? 3 into 3 centimeters. Age of 50 years. So what do you want to do? She attained menopause 1 year back. What is your mode of management? Wait and watch. Go for hysterectomy. Why wait and watch? Why? Yes, automatically once the patient enters menopause, the estrogen is going to get reduced. This whatever the fibroids, these are all always dependent on one hormone, nothing but estrogen. So once estrogen decreases, automatically the fibroid size is going to decrease in the menopause. So it is totally based upon the estrogen. So a menopausal lady, once she presents with asymptomatic fibroid, or there are certain indications where you have to do surgery. So if they are not there, definitely go for a conservative. Never remove the uterus. Once she came, says, day before yesterday I got a patient, this very small fibroid, 3 into 3 centimeters. She was asking for hysterectomy. Now it is to decide whether to do hysterectomy or not. It's an around 38 years age. Now tell me, 3 into 3 you want to do? Why? 38. Still, she may attain menopause something around 48, 10 years. So now how to decide whether to do surgery or what to do in fibroid uterus? Histopathology. Histo? So anything which is interfering, there are some indications. So if the patient is symptomatic, even though the fibroid size is small, but the patient who presented to me was symptomatic. So every month she used to have menorrhagia cycles. So meanwhile the patient landed in anemia. Her HB was 7 because of this menorrhagic cycles. So now I should remove her either the fibroid or the uterus. So if I leave her, meantime she will land in a state of continuous severe anemia and failure. So any symptomatic patient irrespective of the size, okay, you may have to go either for myomectomy or for hysterectomy. Okay, we will deal that in the next things. Yeah, exactly correct. Ramu and Bibu, if they are symptomatic, then go for surgery. Yeah, coming to, it is the most common benign tumor and also solid hormonal. Just now we have discussed, it is dependent on hormone. Which hormone? Estrogen, fibroid. Which other conditions are dependent on estrogen? Which carcinoma? Ovarian carcinoma, na? Breast carcinoma. Come to genitals, then go to surgery. Endometriosis. Good. Next. Which other conditions are dependent on estrogen? Endometrial hyperplasia, very important. A patient with fibroid uterus, always if the patient want a conservative management, go for definitely an endometrial biopsy, because endometrial hyperplasia, endometrial carcinomas, these are all estrogen based conditions. Okay. Okay, normally it is found in reproductive age group. That's what we have discussed. How many types of fibroids are there? Submucosal, intramural, subserosal, cervical, broad ligament. Good, very good, very good. So which is the most common type? Subserosal. Most common. Mucosal. Intramural type. These are most common, otherwise called as interstitial type. Okay. So the questions which were asked you in the regarding the fibroid chapter is, which one causes menorrhagia, which is the most common, which one causes torsion, which one causes wandering fibroid, which one causes parasitic fibroid. So these were the questions asked for you. So coming to each one individually we will see. So which one is most symptomatic? Suppose if we take, if the patient is presenting with menorrhagia, what type of fibroid can be there? Either it can be submucosal or intramural type because it is disturbing the endometrium. Okay. Next, if the patient is presenting with acute pain and torsion, which type can undergo torsion? Because it is on the serosal surface, so it undergoes torsion. So what other abnormality this subserosal can cause other than acute pain and abdomen? Parasitic fibroid, otherwise called as wandering fibroid. What is this parasitic fibroid? So whatever the subserosal is there, it gets sometimes detached and attached to other structures and gets its blood supply from the surrounding structures. So it is called as wandering fibroid or otherwise called as parasitic fibroid, which is depending upon the other structures for its blood supply. Okay, is it clear? So these are all the things they have asked for you. So the fibroid uterus is associated with which of these following? So just now we have discussed endometrial carcinoma, hyperplasia, it can be associated. Yes or no? Why? Estrogen, because of estrogen. And most commonly dysfunctional uterine bleeding patients and any high estrogen conditions, obesity. In obesity we see high estrogen conditions and patients who are taking OC pills. This was asked for you. So patients who are taking OC pills which contains estrogen. So remaining, once we leave this, other risk factors are smoking and black women. Okay. So these are all the risk factors which was asked once for you. So you know, this is submucosal, within the mucosal. This is outside subserosal. You can see it, pedunculated subserosal. Such a fibroids, they get blood supply from the surrounding structures. It is called as parasitic or wandering fibroid. Next, it is disturbing the mucosal lining. So it is submucosal. Intramural, otherwise called as interstitial. Okay. Now tell me. Degeneration is commonly seen in which fibroid? Calcareous degeneration. It is seen in subserous fibroid, calcareous degeneration. Okay. Coming to the blood supply of this fibroid, why this degeneration is seen? Is it seen in the more in the periphery or in the center? Degeneration. What types of degeneration are there in fibroid uterus? Others. Hyaline degeneration, fatty degeneration, red degeneration, very important. Calcareous. Next. Smart. Next. Antena? So, in which part of the fibroid you are going to see this degeneration, either center or in the periphery, and why? So, always the degenerations are seen in the center, and while separating, going for myomectomies also, whenever we actually for myomectomy, what we will do, we will separate it from the capsule. It is called as pseudo capsule. It is containing some capsule around the fibroid. We have to separate the fibroid from the capsule. So the bleeding is very dangerous because the blood supply to the fibroid is from periphery to center. So if we cut in the center, there will not be any blood supply. But if we go through the periphery, there will be blood supply. So even whatever the degeneration you are seeing, it is seen in the center because of decreased blood supply. Remember this point. Okay. Answer is subserous. Most common fibroid associated with malignant. So we will see this, which you cannot answer this, I will tell you. So most common fibroid, remember all these 10 points which are frequently asked for you. So most common fibroid is otherwise called as most common fibroid to undergo malignant change is submucosal. Okay, because it undergoes continuous irritational changes. Continuous, the layer will be altered, endometrial layer. So remember like that, submucous. Retention of urine, in which fibroid we see? Cervical fibroid, because whatever the fibroid is sitting on the cervix, it is near to the urinary bladder. So it will press upon the bladder, causing retention of the urine. I will ask at the end. Okay, remember which fibroid is going to cause retention? Cervical. Torsion? Parasitic? Wandering? Pseudo-Meeks syndrome? It is nothing but it mimics Meeks syndrome, something like a ovarian mass, ascites and all. It is called as pseudo-Meeks. It is not mixed, but it mimics. So any subserous fibroid, because anyway which is out of the uterus, which can put pressure on any other structures. Okay, it is subserous fibroid. Sequelae. That because of continuous endometrial changes, because endometrial hyperplasia, because of the increase in estrogen, endometrial hyperplasia can occur. What the endometrium undergoes many frequent changes. So, which is, the fibroid which is near to that. Okay, coming to sequelae degeneration. Yeah, you have answered Highland. Which is the most common degeneration? Hyaline degeneration. Hyaline degeneration is the most common degeneration. And in which part we see degeneration? Center or periphery? Why? Blood supply is decreased. So calcareous degeneration is seen in subserous. Remember that point. So coming to cystic degeneration. This cystic degeneration they have asked you once in names. So this cystic degeneration is seen in menopausal age rather than the reproductive young age group. And which type of fibroid? It is seen mostly in the interstitial or intramural type. So remember, it can undergo hyaline, cystic, calcification, fatty and atrophy. Even atrophy is also seen. So which of the following is not a degeneration in fibroid? So they can give you atrophy. Atrophy is still a type of degeneration. Coming to red degeneration, which there are many questions in this. So any fibroid in pregnancy, it's a bit very careful to monitor. Okay, why a fibroid in pregnancy? First of all, infertility. Second thing, abortions, preterm labor, premature rupture of membranes. Next, red degeneration. So which half of the pregnancy? I mean, first or middle or last? Where do we see? First trimester, second or third trimester? Most commonly it is seen in second half of the pregnancy. Okay, second to third trimester, or we can see it in the peripheral period, the red degeneration. So how a patient with red degeneration presents? The tumor, when once you touch it, is tense, very tense, tender. The patient presents with fever, pain, abdomen. Okay, and there can be bleeding, painful hemorrhage can be seen inside the fibroid. And appearance, once you take that smear of that red degeneration and once you see it, this was asked for you. It is called as red beef appearance. So whatever the red degeneration part, it appears as a red beef appearance. Where do we see corkscrew glands? Secretory phase in the endometrium, corkscrew glands. Okay. So red beef appearance. So the fibroid, once you take the slide of the fibroid, if you see it, it appears as if like a red beef. Why it is so red? It is nothing but just because of the hemorrhage, in turn because of the hemoglobin. Is it a septic condition or aseptic? The patient presenting with pain, fever, everything, tense, tender abdomen. The fibroid is undergoing degeneration. It is always a aseptic condition. It is not due to sepsis. Okay, even though the patient presents with fever and all, but it is an aseptic. Remember why this red degeneration is occurring. So whatever the blood supply, we just now we have discussed. Once the blood supply to the fibroid is blocked, it is going to cause degeneration. So the blood supply to the fibroid is blocked by the thrombosis of the vessels. So it undergoes degeneration. But in pregnancy, it is called as red degeneration. Okay. So how to diagnose this? The treatment, what you are going to do? Nothing to do. Don't remove the uterus or don't remove the fetus. Just give a course of analgesics and antibiotics and rest. That's it. Okay, automatically the condition will subside. Coming to sarcomatous changes. So how much incidence of fibroid will undergo sarcomatous changes? Malignancy changes. How much incidence? Incidence of 0.5%. So the incidence of this sarcomatous change is only just 0.5%. And most common in which age group? Malignancy change. Just now we have discussed. Postmenopausal, that's what I told you. So any postmenopausal woman, the sarcomatous change is most common in postmenopausal. And which fibroid will undergo malignancy changes? Submucosal, most common in submucosal. So the patient in a postmenopausal age group, so there is either sudden increase in the size of the fibroid or the patient can present with postmenopausal bleeding. Any patient with postmenopausal bleeding, always rule out carcinoma. So when do you call postmenopausal bleeding? Then what is definition of menopause? After? What is definition of menopause? I am not speaking about the age. After how much duration you call it as patient has attained menopause? What is definition of menopause? Cessation of menses for 1 month, 2 months, how many months you will wait? 6 months, 1 year, 2 years, how many? A is 6 months, B is 12 months, C is 18 months, D is 24 months. Answer is? A. B. No one for 18 and 24. So the definition of menopause is cessation of menses for 1 year. Then only call the patient as menopause. But in a case of postmenopausal bleeding, when to investigate a patient with postmenopausal bleeding? Even though the patient has amenorrhea for 6 months, but or in the 8th month or 9th month or 6th month, if she presents with bleeding, definitely investigate a case of postmenopausal bleeding. Is it clear? Menopause is called for 1 year. But a patient with postmenopausal bleeding, when you are going to investigate? 6 months. Okay. Suppose a patient came 7 months and telling doctor, until now I had no bleeding, complete cessation of menses. But since last 5 days I am having continuous bleeding in the 7th month. You want to investigate or not? Yes, definitely. Once the patient crosses 6 months of amenorrhea, always chance of carcinoma is high. Okay, investigate the patient. Remember that point. So postmenopausal bleeding she can present with. So what are all the various things we can say? So that either the fibroid can undergo torsion. Which fibroid? Inversion. Inversion is seen in fundal fibroids. Most commonly inversion. We have seen a very good case while I was doing my PG. Because of the fibroid, the patient presented with some mass out of the vagina. That's it. We don't know. Either it can be fibroid uterus or polyp or inversion or prolapse. Nothing we know. She presented with a very good mass. Once we have examined in the scan and all, the uterus there was no place to examine paravaginally. The mass was this much big. It came suddenly out of the vagina. So once we have examined the scan and all, the uterus was seen. Okay, but some mass was protruding from the uterus. It's nothing but a fundal fibroid. Very big fibroid which suddenly came out. Okay, so which mass can undergo inversion? It is fundal fibroid. Necrosis. So there can be even necrosis once the blood supply is blocked. And infection. Infection is most commonly seen after delivery. So any fibroid can undergo infection mostly after delivery. So this is the hyaline degeneration changes and all. This is leiomyosarcoma picture, HPE pictures. So submucous. Submucous just now, which fibroids will cause menorrhagia? Intramural. Both can cause menorrhagia. Subserous, normally we have discussed this. What is the incidence of cervical fibroid? Incidence of cervical fibroid is 1 to 2%. Okay, sarcoma, incidence of sarcomatous changes is 0.5%. So this parasitic, just now we have discussed. So the fibroid obtains blood supply from the another organ. Which fibroid? Subserosal fibroid. Either it can be omentum. Okay. So coming to very important next, broad ligament fibroid. Sometimes whatever the fibroid is there, it can grow laterally into the broad ligament. Even though it arises from the uterus, it can grow laterally. So how to differentiate either it is really arising from the broad ligament or starting from the uterus and it is seen towards the broad ligament. These are the typical conditions what we see. Suppose a patient presented, we got a case with some very big multiple fibroids and even the fibroid was extending into the broad ligament. We don't know really it arised from the broad ligament or it is coming from the uterus and sitting here. So how to know? That is what it is called as true broad ligament and false broad ligament. So it was asked for which of the following is the feature of the true broad ligament fibroid. Which of the following is the feature of the false broad ligament? So normally what does this do? The false broad ligament, it will arise from the uterus and grow towards the broad ligament. Whereas true broad ligament, it should arise from any one of these structures. Either from the broad ligament directly or from round or ovarian ligament or surrounding the structures. So the origin of the fibroid is very important. In a case of this true broad ligament fibroid, sometimes the fibroid will be lateral to the blood vessels. Is it clear? So this is the uterus. Suppose it is a true broad ligament. True, what did we say? It should arise from the uterus and it should be something sitting like this. Suppose in a case of true broad ligament fibroid, whatever the vessels and all, the position of the vessels is different. Whereas a false broad ligament fibroid, the vessels we see medially. Is it clear? Because it is arising totally from the either round ligament, ovarian ligament, or directly from the surrounding structures. Whereas here there is no gap, it is directly arising from the uterus. Which vessel? This is which vessel? And one more, the position of ureter. Most of the times even we have to check the position of the ureter. The chances of damage to the ureter is very high in a case of broad ligament fibroid. So symptoms, what symptoms? Mostly that a patient can be asymptomatic. That's what in the last clinical scenario I told you. Lady came with just for routine checkup, but on ultrasound scan it showed a fibroid. So most of them 50% are asymptomatic. Rest of the patients they can present with menorrhagia. So they have asked you, which of the following is the cause of menorrhagia in a fibroid uterus? Why there will be menorrhagia? Increased vascularity. Next. Okay, next. And other causes. Next is increased vascularity. It is an estrogen dominant. So endometrial hyperplasia. Always a fibroid patient go for DNC. Why? Endometrial hyperplasia. So to rule out endometrial carcinomas and hyperplasias. So the cause of bleeding can be increased vascularity, endometrial hyperplasia, increased blood supply as what she told, and there can be imbalance sometimes, which is a vasodilator, which is a vasoconstrictor. So thromboxane is a vasoconstrictor, prostacyclin is a, where else we see this imbalance? Preeclampsias, eclampsias, hypertensive patients, okay. So imbalance between these two can cause, which thing is going to increase to cause bleeding? Thromboxane or prostacyclin? Prostacyclin, because prostacyclin is a vasodilator. So there will be excess bleeding. Coming to metrorrhagia, what is this metrorrhagia? We know menorrhagia. What is this metrorrhagia? Intermenstrual bleeding. So why there is intermenstrual bleeding? This was asked. The cause of metrorrhagia in a fibroid uterus. What is the cause of the intermenstrual bleeding? There can be whatever the polyp is there, it can be infected, or else the submucous polyp, once it gets ulcerated sometimes, infected, next landing in ulceration. So this ulceration, whatever the surface, it starts to bleed. So this is the cause of metrorrhagia. So this was asked, these are all asked, even though they are minute points, fibroid uterus, enter each point was asked. Which of the following is a cause of metrorrhagia in a fibroid uterus? Next, dysmenorrhea. Are both dysmenorrheas are seen or only one type? How many types are there? How many types? Huh? Yeah, someone is answering. How many types? What are the three? Congestive, spasmodic. Third thing is layer. What is that layer? Dysmenorrhea, basics. What is the third type of dysmenorrhea? Congestive, spasmodic. Next. Membranous, congestive, spasmodic, membranous dysmenorrhea. So when do we see congestive? When do we call it as a congestive dysmenorrhea? So if the patient presents with dysmenorrhea even before the onset of bleeding, congestive type. Spasmodic along with the bleeding. Suppose today her menses starts, even before starting, suppose tomorrow is her period, if she gets pain today, it is congestive. And spasmodic is if bleeding and the pain starts on the same day, that is spasmodic. Then what is this membranous? Patient passes a membranous like structure through the vagina. So if the patient is having bleeding while passing that membranous structure, it is called as membranous dysmenorrhea. So which is pathological, congestive or spasmodic? What is the most common cause of congestive dysmenorrhea? Most common cause of congestive, is it pathological? Which is physiological out of these two? Why? Why there is spasmodic? What is the cause of spasmodic? Tomorrow's question. Nowhere related to ligaments. Once again read and come. So tell me out of these two, during normally, suppose a young girl they are having dysmenorrhea. So there will be no cause, but the patient will be having dysmenorrhea. Why? And which is seen in the young girls, either congestive or spasmodic, which is dangerous out of these two. Don't read any other book. It is given only in Shah. Just you can read 2 lines from the Shah. That is tomorrow's exercise for you. Okay. Coming to congestive dysmenorrhea. Why there is congestive dysmenorrhea in this patient? It is mainly because of pelvic congestion. So that's why there is congestive dysmenorrhea. And why there is spasmodic? So sometimes what it will do, the polyp or whatever the fibroid, so it tries to expel it sometimes. So that time it can cause spasmodic dysmenorrhea. This was asked. So why a patient, without seeing the slide, tell me, just think and tell me. A patient with fibroid uterus, why a patient can have infertility? Okay, carnal fibroid can block the tube. Very good point. So next, each one. Okay, bleeding implantation problem. Huh? Okay, if fibroid, it will prevent the ascent of the sperms. Very good. Next, this was asked. These are all asked questions for you. That's why I'm asking. Next, what are all can be the causes? So it's very simple. Huh? No, I am speaking why a patient with fibroid uterus can have infertility causes. It is mainly because of what once you said, it can be distortion of the uterine cavity normally. So the implantation can be affected. Something like a cornal fibroid which is sitting at the end of the tubes. There is no other how the sperm will go, how the egg will come. So there can be chances of the obstruction. Next, or as what he has said. So the implantation site is not there. Fibroid is occupied that site. So defective nidation can be there. And other than this, even sometimes in a case of fibroid uterus, there can be associated endometriosis. Why? Estrogen. So there can be associated endometriosis and sometimes even PID. So these are all the conditions why a infertility patient can present with a fibroid uterus patient can present with infertility. So other than infertility, patient with fibroid uterus, if she conceives, she can have abortion, at the same time preterm labor, premature rupture of membranes and IUGR. Okay. So what are all other symptoms a patient other than the menorrhagia and other than the infertility? So they can have sometimes a patient present with pain other than the dysmenorrhea. It is because of the pressure of the uterus on other structures. The case what we have done, the pressure was sitting patient, it was sitting on the uterus colon and all. So it was causing constipation. Which fibroid can cause bladder symptoms? Cervical fibroid. Why? It will put pressure on the bladder. And other than this, a patient can have anemia at the same time polycythemia because of excess bleeding, anemia and polycythemia. What is pseudomix syndrome? It's seen in which fibroid? Subserosal fibroid. It is parasitic fibroid. So a patient with pseudomix syndrome, they present with ascites, mimicking a original Meeks syndrome. Okay. How to diagnosis? Diagnosis, we know first is examine the patient, abdominal examination and paravaginal examination. Once you do examination, next you want to go for a scan, ultrasound scan. On ultrasound scan, we can diagnose the fibroid. What are the differential diagnosis? Most common differential diagnosis. Ovarian mass, we can see paravaginal examination itself, we can say. Pregnancy. Pregnancy, I can see the fetus clearly. Most common DD is adenomyosis. We can't differentiate whether it is adenomyosis or fibroid uterus. That is the thing which is differentiating until unless we get a HP picture. And always a fibroid uterus, which are all extra investigations I told you to do. Just now I told you one important investigation we should do. DNC to rule out endometrial hyperplasia and carcinoma. Always a fibroid uterus, go for DNC. Next, other than that, any patient endometrial biopsy, that anyway DNC we are doing, and pap smear. So we have to take a pap smear if we are going for hysterectomy. That is common for any patient. And other investigations where we can detect is MRI, CT scan. This is why this picture MRI is very important. Recently I got a case from ESI that scan report showed only 4 fibroids. Infertility patient with 4 fibroids. Can I remove her uterus? The management of a young female patient with 4 fibroids, not young, she is around 32 years, okay, 32 years patient presented with symptoms of secondary infertility, not primary infertility, but a scan report showed 4 fibroids. Now what is the management? Karthik? Karthik's friend, male friend. 32 years కి తీసేస్తావా యూట్రస్ ని? సెకండ్ ఇన్ఫర్టిలిటీ అయితే ఫస్ట్ బేబీ. అండ్ ఈవెన్ ఫర్ ముస్లిం పేషెంట్ 10th baby is very important. She'll kill you if you say that you will remove her uterus. Every baby is precious. So patient with, that's what the clinical scenario. Infertility patient, they better go for a myomectomy. Okay, don't go for hysterectomy. Always an young age, the question asked you about infertility, the best option is myomectomy, not hysterectomy. In such case, even though 4 fibroids are there, but once I have examined, I felt like there are multiple fibroids rather than 4. I felt there are many. So even before, prior to surgery, I have explained the patient there can be even 20 fibroids as per clinical examination. But fibroids, we can't see in the scan how many fibroids typically. In a case of multiple fibroids, we have to go for very one important investigation, which is MRI. Patient was not affordable. We proceeded for surgery. On opening the uterus and abdomen and all, totally I have to remove 34 fibroids. I removed 34 fibroids. Still 5 to 6 fibroids were left out because of the still patients was very important thing is hemorrhage. So once you, that's what I told you, once you start doing for myomectomy, peripheral, the blood supply is periphery, so there will be excess bleeding. So meantime the patient, we should correct at the same time, maintain the whatever the hemorrhage, at the same time I have to remove the fibroid. So we are successfully able to do myomectomy for 34 fibroids. Some 4 to 6 fibroids we have to leave because the patient condition will deteriorate if still go on plucking the fibroids. Okay, so that's the importance of MRI and CT scan. So if I have done MRI, I can clearly see how many fibroids and what is the position, especially in case of broad ligament fibroid and all, if it is sitting on the ureter and vessels and also. Before going for surgery, it is very important. So other investigation is CT scan and MRI where we can diagnose this. Yeah, Kausar, you are correct, it is myomectomy. So these are the fibroids pictures, nothing but to see. We can see how many fibroids in a case of MRI and all, we can visualize clearly. So this is the ultrasound scan picture, here we can see. So which investigation can differentiate polyp or a fibroid within the endometrial cavity? I have done a scan, some thickened mass is there in the endometrium. I don't know either it can be endometrial hyperplasia, fibroid or polyp. So which investigation you want to do to diagnose within the scan? I told you yesterday. Exactly. Basic thing. Through scan, how can diagnose? I have just done a normal scan. There was some thickened endometrium, very large. I don't know if it is fibroid, I don't know polyp, I don't know endometrial hyperplasia. Now I want to make it clear. How can I do? One thing I can go for is saline, sonohysterogram. Just inject the saline. That in the yesterday film I have showed you. So what did I have shown you? So the fluid is there. Now you can clearly differentiate the fibroid or polyp. And fibroid has some specific features. The polyp, the whatever the sitting edge is, the fibroid has got a broad edge, whereas polyp a small edge. And hypoechoic lesion fibroid, whereas a polyp is isoechoic. So there are some features where with saline sonogram I can differentiate. But the definitive diagnosis, how can I confirm? Other than ultrasound. I saw some mass. I don't want to do saline histosonogram. So I have got other option to confirm it, either it is fibroid, polyp or hyperplasia. Which investigation? DNC, how can you do DNC? You have to remove that. I don't want to remove. I don't want a therapeutic procedure. I am asking for diagnostic procedure. I have to confirm. Histoscopy, very good. Histoscopy, just put a scope into the uterus and see what is there inside. Okay. So that is what down. This is the histoscopic picture. It's clearly seen what is there and the position, everything. This is which picture? This is which picture? Laparoscopic picture. This is ondal fat. This is the uterus. Okay, this is the small fibroid. Which fibroid this is? Subserosal fibroid. This is which fibroid? Cervical. Importance of cervical fibroid. Tell me fast. Next, incidence. So treatment. So a menopausal woman, you want to treat or not? So depending upon the symptoms and other things, I'll tell you when to treat, when not to treat. In a case of mostly in a asymptomatic menopausal woman which was diagnosed accidentally, never give treatment for fibroid uterus, never do a hysterectomy. That is the important thing. So they'll ask you like this. So a postmenopausal woman who is asymptomatic, on routine examination, there was a fibroid uterus. So what is the management? Don't mark it as a hysterectomy. Asymptomatic, Don't go for hysterectomy. Just wait and watch. So once again she has to repeat her scan and come for follow-up. Okay. The best investigation during that time is, how do you follow? Other than checking the scan and all, how do you follow up? So next time you advise the patient to come for a scan so that you will see whether it is increasing or not. Next, other than that, what follow-up you want to tell the patient? Very important in a postmenopausal age. Pap smear, okay. Other than pap smear? Someone is answering. No, not bleeding. Which investigation you want to do? Postmenopausal fibroid uterus, totally asymptomatic. What follow-up you want to do? A follow-up I told you. So what investigation you want to do? No way we check estrogen levels in postmenopausal. No investigation. DNC, very important. Why in a postmenopausal DNC? Endometrial hyperplasia, endometrial carcinoma, very important. So always a postmenopausal, she presents with fibroid, it is indicating that high estrogen status. So high estrogen not only causes fibroid, even endometrial hyperplasia and carcinoma. So the investigation which you should do in a case, such a case is definitely dilatation and curettage. Do a DNC. What is treatment for red degeneration? Termination. Termination, you want to terminate? Just antibiotics, analgesics, continue the pregnancy. So when do you want to treat a fibroid? There are certain indications for definitive. So the question says there is something like a 8 weeks fibroid or 6 weeks fibroid. The patient is totally asymptomatic. Either you want to go for surgery or not. So this is the treatment. When do we do a treatment? Normally treatment is indicated when the tumor is greater than the fibroid is great. Normally how we measure the size of the fibroid? We measure it in the, as if like a pregnant uterus. So 8 weeks. When does it become a pelvic organ? Uterus, pregnant uterus. Lower border of umbilicus. Lower border of the umbilicus. 20 weeks. So the same we measure the fibroid uterus. So that when what is 14 weeks means how many fingers from pubic symphysis? So when does it become a pelvic organ? Next, tell me how many fingers? 14 means 2 fingers. 18 case 2 centimeters. That's it. Okay. So if the tumor is greater than 14 weeks size, or if there is sudden increase in the size of fibroid, what did I tell you? There can be sarcomatous changes. So very important if there is sudden increase in the size of the fibroid, and we don't know what type of the fibroid. It is something like degenerative changes and all seen. Something hypoechoic, something isoechoic. Why we don't proceed for expecting management means there can be malignancy changes. So once you do not know, you are not sure of the nature of the fibroid, definitely go for surgery. And any symptomatic patient, that in the last case I told you, she was having only 3 into 3 centimeters, but she was symptomatic, presenting with menorrhagia cycles. So any patient, if she comes with symptomatic, either 1 into 1 or 2 into 2, you are not bothered. If everything is normal and the culprit is fibroid, remove that fibroid. Okay. So any symptomatic patient. So before going for surgical management, I can give some drugs by medical management to decrease the size of the fibroid. But always remember, the medical management is a temporary treatment. In a case of fibroid, it is not a permanent treatment. Suppose a patient, engaged patient, she want to continue her pregnancy. That's what I told you, secondary infertility. Can I remove her uterus? No. But I have to decrease the size of the fibroid. It's very quite common. A submucosal fibroid or interstitial fibroid will be seeing in infertility patient. She will be having mild symptoms. But I have to treat her by not removing her uterus. But how? That's why we use medical treatment. And the important thing of this medical treatment is, especially with this GnRH analogs, a very important thing is we give it just before surgery. So any patient, if you want to do a surgery, we give it. What are all important things why we give this GnRH analogs is it decreases the size of the fibroid, first thing. Next, suppose if you want to do a laparotomy, it decreases the size of fibroid. So you can go for laparoscopically. Suppose if you don't want to do a laparoscopy, it decreases the size of the fibroid. We can do vaginally. So, okay, that's how it decreases. And one more, it decreases the bleeding. It decreases the size of the fibroid. Vascularity also it is going to decrease. But the main side effect with this GnRH analogs is it is very costly. And what is the most common side effect it causes? Osteoporosis. Okay, be careful. You should never give a continuous GnRH analog because it is going to cause osteoporosis. Next, once you stop this GnRH analogs, there is rebound increase in the size of the fibroid. So never give a continuous GnRH analogs. Definitely the definitive treatment is surgery. These are used only for a temporary purpose. Okay. So what are all the drugs we can give? We can give to stop bleeding progesterone. Which progesterone? Normally which progesterone we give to stop bleeding? To stop bleeding. A patient with menorrhagia, not about fibroid. What is the most commonly given progesterone? Tell me the types of progesterones. Ramu, you should tell me tomorrow what is Primolit 10 and what does it contain, which hormone it contains. Online, Ramu. Yeah, Kausar, you are correct. Kausar answered. Still, other than that, what progesterones you know? Norethindrone, still? Estradiol. I am asking about progesterone. Huh? So most commonly what we use is norethindrone. In a case of menorrhagia cycles, norethindrone is the drug of choice, or else medroxyprogesterone. You will be giving in your SHA book, you will be reading in a puberty menorrhagia cases, you are going to give medroxyprogesterone acetate, norethindrone. Okay. So that is the most commonly used progesterones. And what is the most common side effect of this danazol? Why it should not be used in young patients in hirsutism? So any young patient never prescribe a danazol. It is going to cause hirsutism. It is one of the most common side effects. So these are all the drugs which are used as a medical management to stop the bleeding temporarily, but not a permanent management. Yeah, Ramu, it is hirsutism, correct. This first point we have discussed. So we are going to give GnRH unlocks only prior to surgery, so that we can decrease the size of the tumor, but not a temporary, but not a permanent thing. So what are all other treatments? Fibroid, surgical treatments, how many are there? Others. What are all the fibroid treatment? Other than medical, surgical management, how do you manage? Myomectomy, hysterectomy. Other than myomectomy, hysterectomy, embolization. So the third thing is embolization of the vessels. Okay. Myomectomy. Coming to myomectomy, main thing why we do myomectomy is, especially in the previous case I told you, even the 34 fibroids, why I didn't go for hysterectomy. No one will go for his myomectomy in such a case, but I have to do a myomectomy procedure. Why? Because I have to retain her uterus, because she was having infertility. So any patient with infertility, it's better to go for myomectomy. Don't go for hysterectomy. But the treatment for multiple fibroids is always a hysterectomy. Okay. The patient presented with multiple fibroids, it is very highly impossible to take out every fibroid, something like a flower plucking out. It's very difficult. Okay. Multiple fibroids, it is the treatment, the best treatment is hysterectomy. If there is no other alternative, then only go for myomectomy. And one important thing is, even though you remove, sometimes they can recur. That is very important thing. So a patient came to you for infertility. There was a fibroid. You remove the fibroid. So next, you should not neglect the patient. Once again, it can recur after 1 year or 2 years. So why? Because the culprit is estrogen behind. So always a patient with fibroid should be followed. So this is vaginal myomectomy, what they are doing. Vaginally, what are all the various routes? So either you can go for vaginal route or laparoscopic route or open route, laparotomy. So vaginal myomectomy, when you are doing this, remember this very important point. So whenever a fibroid, it should not be greater than 8 weeks size. So it should be less than 8 weeks size. Then only go for vaginal myomectomy. And very important thing is, in a case of this point was asked. So the size should be less than 8 weeks to go by a vaginal route. So this is the fibroid. You can see this is the total wall. So they are removing this. They are holding this fibroid and removing it. So what are all the names? So main indication myomectomy where do we do is infertility patient. So if it is a fundal fibroid, remember this name. It was asked long back. Bonis hood operation. The name of the operation is Bonis hood. We do it in a fundal fibroid case. Suppose if it is a case of many fibroids are there. So how do we go? Anterior route or posterior route? So in the previous case I told you. So the patient was having totally multiple fibroids. So how to do myomectomy? So here one, here. So how to do this multiple fibroids? This was the case what I have seen. So how to do a myomectomy in such a patient? So cut everywhere like this, like this, like this, like this, like this, like this. Incise every part of the fibroid and remove it. Then suture it. Nothing will be left out. No uterus. The uterus even before she conceives it will rupture. So always in a case of multiple fibroids, what I have to do? Just give a midline incision or whatever the prominent part is. Then open, then go tunneling. It is called as tunneling. Okay. I am not going to give multiple incisions. Remember, only one incision as if like a digging. Okay. Through that incision, I will remove this fibroid. Next, I will find the place to go to this next fibroid. Okay. Like that, I will tunnel and remove through only one incision. I try to avoid maximum incisions. Suppose if I have done this total, but on the posterior wall there are there. I can't, sometimes I can go from anterior to posterior, but it is not safe. Okay. Then in such a cases you can go, but always remember, avoid multiple incisions, because next time once she conceives, the chances of rupture of uterus is very high. And remember this point also. So once you do a myomectomy patient, the important thing to tell the patient in an infertility patient is, it's better to go for a cesarean section. So next time once she lands in a pregnancy and she becomes pregnant, she should go for a cesarean section under regular follow-up. That is the important point to tell in a myomectomy case. So there are various things. I already told you I have to leave 4 fibroids because it was 34 fibroids. Already there was a increased blood loss in that cases. So what are all the things what are all the things I can do to decrease the blood supply? I cannot avoid blood supply even though whatever I do. I can decrease the blood supply. So there is a clamp called as myomectomy clamp. The clamp applied, it blocks the uterine vessel. So it will clamp like this. Something like a round thing. It will clamp the vessels like this totally. So you can apply the myomectomy clamp. Or else what I did in my case was I gave vasopressin injections directly into the total part where I am going to do tunneling and all. So I can give vasopressin injections. That is called as vasopressin injections. It is going to decrease blood supply. Then immediately I can remove the fibroid. Once you remove it, then don't wait until all you remove, then suture. So whatever the space is left out, the pseudo capsule will be there. I am separating the fibroid from the capsule and I am removing the fibroid. Immediately I have to close that gap. Once the vasopressin effect goes off, it will start spurting something like a tab. So immediately once you remove the fibroid, I have to close that gap. Go for next fibroid, close that gap. Okay. I am whatever the gap is there, I am obliterating it. That is how we should do. So the vasopressin ring. Or else there is one more, rubber catheter. What if no other alternative in a government hospital? What we do? So simple. We'll take a rubber catheter and we'll tie all these vessels. We are going to block uterine and the ovarian vessels at the same time. So here the junction is there, the ovarian vessel, uterine vessel. So I'll block this junction by tying with a rubber catheter. This is one more method. Or else just now we discussed GnRH and locks if the patient is affordable but very costly. It costs something around 2000 each ampoule. Okay. So these are all the various things by which we can decrease blood loss during surgery. This was asked, which of the following can decrease blood loss during surgery? This is laparoscopic myomectomy. Here you can see this is the fibroid along with uterus. So they have incised and they are removing the fibroid and the uterus is sutured. Posterior part of the uterus. Okay. And we can go through even through hysteroscopic route. This is the hysteroscopy. That's what I told you. So to diagnose it mostly by hysteroscopy route. And you, at the same time, if it is a small fibroid in infertility patient, I will go for hysteroscopic myomectomy. What are all the complications? So there can be hemorrhage, most common complication while doing this myomectomy procedures. That's what I told you, how to stop my procedure because there was bleeding. So hemorrhage, it was because these fibroids whatever are there, if it is a multiple fibroid and very big fibroid, this can sit on the bladder and bowel. So the damage to bladder and bowel is very important. In the case whatever I have seen, other than this there was a very big cervical fibroid. This much big cervical fibroid. If I try to remove that fibroid, definitely I am going to injure urethra, at the same time bladder. So these are all the complications. Even bowel can be sometimes be injured if it is othered posteriorly. And because of these surgeries, blood loss and all, there can be infection and any pressure symptoms. So once this fibroid can compress, it can cause intestinal obstruction. And I have done so once if you give any scar on the uterus or any surgery in the within the pelvis, it is going to cause adhesions. And one more very important thing. So you can answer which of the following is a complication. You can say drama A, B, C, D are correct. But remember, there can be recurrence. Always remember. So it is one of the complication. Even though you remove the fibroid, it can recur once again. So the recurrence is also one of the complication. Coming to hysterectomy. When do you do a hysterectomy in a fibroid uterus? So in order to do a hysterectomy, the main thing is the patient might have completed childbearing age group. The first important thing to satisfy is the patient should have finished the childbearing. Next thing is she should be symptomatic. Any asymptomatic, never go for a surgery. So if the question is the definitive treatment, it is not even myomectomy, it is hysterectomy. But depending upon the age of the patient, depending upon the clinical scenario, what they gave you. So answer the question carefully. So whenever this we have already discussed. So patient with pregnant fibroid uterus, there can be abruption and there can be even bleeding, abortion sometimes, and labor there can be dysfunctional labor. So the process of labor will not be normal, and if it is something like a cervical fibroid and all, there can be breech presentation, malpositions and malpresentations, and the chances of cesarean section is high in a case of fibroid uterus. So these are all the complications which was asked for you. So this is a hysterectomy specimen. So this is the one fibroid you can see, second fibroid, this is the third fibroid, multiple fibroids. So simple, only three fibroids. So the other alternative is embolization. So other than this, I have got one more. What I do is I pass a catheter through the uterine artery and embolize these vessels whichever is supplying the fibroid. Here you can see. So this is the thing. So they have embolized this fibroid, whichever the blood supply which is supplying this fibroid. Okay. Rest of the uterus, the blood supply is maintained. This is the other alternative, embolization.